Welcome to the Hospital Medicine Unplugged podcast.
Today we're doing a deep dive into epistaxis, nosebleeds, specifically how we manage them effectively in the inpatient setting.
Right, it's one of those things, isn't it? Super common overall. Something like 60% of people have a nosebleed at some point.
Exactly. But the patients we see admitted for it, they're a different ball game entirely compared to, a simple bleed someone sees their GP for.
That's the crucial point for hospitalists. Only about 6% of people ever seek medical help for epistaxis, but the ones ending up in the ED or admitted, maybe 1 in 200 ED visits, they often have significant underlying issues.
Yeah, they're often older, have multiple comorbidities, or they're on medications, especially anticoagulants or antiplatelets, that make stopping the bleeding much, much harder.
And that's what turns a potentially minor anterior bleed into something severe, often refractory to simple measures, and really resource-intensive for the hospital.
Absolutely. The usual first aid people try at home often just doesn't cut it. We end up managing not just the nosebleed, but the complex patient attached to it.
So our goal today is really to synthesize the latest evidence, the guidelines, and move maybe beyond just stuffing gauze in the nose.
Right. We want to give you, the listener, a clear, systematic way to assess and intervene. We'll look at newer options like TXA, aiming to, improve outcomes, cut down on rebleeding rates.
And ultimately, reduce how long these patients stay in the hospital and how many resources we pour into just getting the bleeding stopped.
Okay, so let's start right at the beginning. Patient comes in, active, maybe even massive nosebleed. Before we even think about looking up their nose, what's the absolute priority?
Stability, right, always. Airway, breathing, circulation, ABCs.
Exactly, it's rare. But truly massive epistaxis can cause hemodynamic instability. We're talking potentially significant blood loss, maybe even up to 1 liter or more in really severe posterior bleeds.
So airway first. If they're swallowing huge amounts of blood, getting nauseous, vomiting, that's a major aspiration risk. We need to secure that airway.
And then circulation. What are we watching for immediately?
Signs of hypovolemia. Tachycardia is usually the first clue. Then maybe orthostatic hypotension, dizziness, even syncope if it's bad.
And if you see those signs, profuse bleeding plus signs of shock, that's an immediate go signal, isn't it?
Absolutely. Get IV access, start fluids, think about blood products, get a type and cross ready. That all happens before you're digging around trying to find the bleeder.
And let's not forget safety. Universal precautions. Gloves, gown, face shield, especially if there's active spurting. It can get messy.
Okay, so we've got the patient stable or we're working on it. We're safe. Now, the history. What are the absolute must-ask questions for the hospitalist?
You need the basics, of course. How long has it been bleeding? How bad is it, roughly? How often does this happen? And crucially, which side? Or both.
And can they tell if it's mostly dripping out the front, or do they feel it running down the back of their throat? That anterior versus posterior hint is huge.
It really is. But for us, the inpatient providers, the most critical part of the history is digging into those comorbidities and medications. That's what really tells us the risk level.
Yeah, this is where we find the why. We need to know about any known bleeding disorders, liver disease, kidney problems, any hematologic issues like leukemia or low platelets. Family history, too, sometimes.
Definitely. And the medication list needs a fine-tooth comb, specifically anticoagulants, warfarin, DOACs like apixaban, rivaroxaban.
And antiplatelets, aspirin, clopidogrel, ticagrelor, prasugrel. These are probably the single biggest factor driving severity and making bleeds hard to stop in our population.
We also need to ask about things that might just irritate the nose locally. Intranasal steroid sprays, antihistamines. They can dry things out.
And what about the hospital environment itself? Supplemental oxygen, especially high flow or CPAP, those notoriously dry out the nasal mucosa.
Good point. Okay, history gathered. Now the physical exam.
Yeah.
We need to try and actually see where the blood is coming from. How should we set that up?
Patient sitting up, leaning forward a bit, get some towels or an emesis basin ready, and you need good equipment.
Yeah, a pen light just won't cut it here, will it?
Not usually, no. You really need a bright headlight, a nasal speculum to open the nostril gently, and definitely good suction available. A Yankauer or Fraser tip.
Trying to find a tiny bleeding point when everything's filled with clot and fresh blood without suction, it's basically impossible.
Right. And the main goal of this initial look is that big question. Anterior or posterior? We know most, maybe 80–90% are anterior. Usually that Kieselbach's plexus or Little's area right up front on the septum.
Exactly. Easy to see, relatively easy to treat if you can visualize it. But what flags a posterior bleed?
Well, if you look carefully up front with good light and suction, and you see no obvious source, but there's still significant bleeding,
Or if the patient is consistently reporting blood dripping down their throat, even if the front seems quiet.
then you have to suspect posterior. Those are the 10–20% that are much more likely to need admission, specialist intervention, packing.
And that suspicion immediately changes the game plan. You're probably calling ENT sooner rather than later.
Okay, let's talk etiology then. Why do these happen? We can break it down into local causes and systemic ones. Local first.
Local factors are behind most of those anterior bleeds. And in the hospital, trauma is a big one.
Yeah, often iatrogenic, unfortunately. NG tube placements, nasal trumpets, even oxygen cannulas that don't fit right and cause pressure points. Digital trauma, too, nose picking.
And then there's the mucosal environment itself. We mentioned the dryness from hospital air, supplemental O2.
That desiccation makes the mucosa fragile, makes those superficial vessels in Kieselbach's plexus prone to cracking and bleeding. Add in things like nasal steroids the patient might be on.
And it's a setup for a bleed. Other local things, less common but worth thinking about?
Sure, infections, inflammation, sometimes septal perforations, rarely a tumor.
When should we really worry about a neoplasm?
Usually if it's recurrent, really severe, strictly one-sided bleeds, maybe with other symptoms like facial pain or nasal obstruction. But for most inpatients, it's trauma or dryness.
Okay, now the systemic drivers. This is really the core issue for hospital medicine, right?
Absolutely. Coagulopathy is huge. Either hereditary, like von Willebrand's, or acquired.
Acquired like advanced liver disease, affects clotting factors, severe kidney disease, affects platelet function. Blood cancers can cause thrombocytopenia.
Exactly. If the platelets are low or the INR-PTT are way off, you're treating that systemic issue alongside the local bleed.
And we keep coming back to antithrombotic therapy. It's not just a risk factor. It's often the major driver of why the bleed won't stop and why it comes back.
We have to know exactly what they're on, why, and think about if we need to adjust it, even temporarily.
Beyond clotting, other systemic things, hypertension comes up a lot.
Yeah, the thinking is that while high BP might not start the bleed, it definitely makes it worse once a vessel is open. More pressure, more bleeding.
So getting blood pressure under reasonable control is part of that initial stabilization. Makes sense.
And then there are specific vascular disorders, hereditary hemorrhagic telangiectasia, HHT.
Right, Osler-Weber-Rundu syndrome. That's different. That's fundamentally abnormal blood vessels, telangiectasias in the nose and elsewhere. Bleeding there is a manifestation of a systemic disease. Requires a different approach.
So putting it all together, there's this statistic that something like 45% of hospitalized epistaxis patients have underlying systemic illnesses contributing.
And that really nails it, doesn't it?
Yeah.
It tells us that when we see epistaxis severe enough for admission, we're almost never just dealing with a nosebleed. We're managing systemic illness presenting locally.
Which justifies why it takes more resources, more thought, maybe more specialized care than a simple community nosebleed.
Okay, so we've stabilized, we've done our history and initial exam, we understand the likely drivers. What's the first treatment step? Let's talk first-line management.
Back to basics first. Compression. Simple digital pressure, but it has to be done right.
How so?
Pinch the soft lower part of the nose below the nasal bones continuously. No peeking. For a good 15, even 20 minutes. Time it.
And critically, patient position. Lean forward.
Yes. Not back. Leaning back means they swallow blood, get nauseated, maybe vomit, and we can't see anything if we need to examine them later. Forward, let the drain out.
Okay, so compression first. If that's not enough after 15, 20 minutes?
Then we often reach for topical vasoconstrictors. Things like oxymetazoline or phenylephrine.
How do we use those? Spray. Pledgets.
Either works. A couple of sprays in the affected nostril. Or, maybe more effectively, soak a cotton ball or pledget in the solution and place it gently inside the nostril, then continue compression over it.
And these are pretty effective, right? Maybe 65, 75% success for anterior bleeds?
They can be, yeah. They constrict the small blood vessels locally. But there's a big but for our inpatient population.
Ah, the systemic absorption issue.
Exactly. In patients with significant cardiovascular disease, CAD, heart failure, really bad hypertension, absorbing these alpha agonists systemically could, theoretically, cause problems, raise blood pressure, increase heart rate.
So caution is needed in those high-risk patients. Use it, but be mindful. What about ice packs? People always seem to try that.
Yeah, ice to the bridge of the nose or back of the neck. The AHA review actually looked at this and found the evidence is pretty weak and inconsistent. Doesn't seem to be a reliable evidence-based step.
Good to know. Okay, so compression, maybe vasoconstrictors. What's the next big thing, the real update in first-line care?
This is where topical tranexamic acid, TXA, comes in. The evidence here has really shifted the paradigm.
Explain how TXA works in this situation. It's an antifibrinolytic, right?
Exactly. It stops the breakdown of blood clots. Normally, your body forms a clot, and then enzymes like plasmin come along to dissolve it eventually. TXA blocks plasminogen from becoming plasmin right there at the site of the bleed.
So it basically stabilizes the clot that's trying to form over the bleeding vessel. It reinforces nature's plug.
Precisely, and the data comparing it head-to-head with traditional anterior packing is really quite striking.
What did that network meta-analysis show?
It showed topical TXA was significantly better than anterior packing at preventing rebleeding. The odds of rebleeding within 2 days were almost halved, an odds ratio of 0.45.
Wow, nearly 50% reduction in rebleeding at 2 days. What about longer term?
Even better at 7 days odds ratio of 0.33. So about a 67% reduction in rebleeding risk at 1 week compared to traditional packing.
That's clinically massive for a hospitalist. Fewer callbacks, fewer repeat interventions, potentially shorter stays.
Absolutely. And it's not just about efficacy. The New England Journal Review highlighted other advantages too.
Like what? Faster, maybe?
Yes, often faster hemostasis, sometimes within 10 minutes. But maybe the biggest win is patient comfort and less morbidity.
Because packing is miserable.
Right.
Shoving gauze or a balloon up an already sore, bleeding nose.
It's uncomfortable going in, uncomfortable while it's in, and then potentially traumatic coming out, risking rebleeding. Plus, there's a small infection risk.
And TXA avoids all that.
Yeah.
How do you apply it topically?
Usually, you take the liquid IV form, drop maybe 5 milliliters, which is typically 500 milligram, soak a cotton pledget or a strip of gauze in it, and place that gently into the bleeding nostril. Leave it for 10-15 minutes. Simple, non-invasive.
So putting this into our algorithm,
Yeah.
where does TXA fit?
Right after direct pressure and maybe a trial of vasoconstrictors have failed, it should be the next step before jumping to invasive packing, especially if you can't clearly see a single point to cauterize.
That seems like a major practice change. Empowering bedside nurses or ED providers to use topical TXA early could potentially avoid a lot of packing and maybe even some ENT consults.
That's the implication, yes. It's supported by guidelines as a first-line non-invasive therapy when cautery isn't immediately feasible.
Okay, but what if TXA doesn't work, or if we can actually see the bleeder clearly, then we escalate, right?
Right. If you have good visualization, good light, good suction, and you can pinpoint the vessel, then targeted cautery is the preferred next step.
Seal the deal, basically.
Exactly. If you can see it, you can treat it directly.
What are the options for cautery? Chemical versus electrical?
Chemical cautery is usually silver nitrate sticks, good for small, easily accessible anterior bleeds, like on Kieselbach's plexus. You gently roll the stick over the bleeding point.
Limitations.
It's fairly superficial, might not work for brisk bleeding, and you have to be careful not to cauterize too wide an area or both sides of the septum at the same time, risk of perforation.
And electrocautery.
That's generally considered the gold standard if available, and the user is trained, usually bipolar cautery. It's more precise, more effective for slightly larger vessels or more brisk bleeding. Needs specialized equipment and training, though, often done by ENT.
And the data suggests getting that cautery done early, if possible, leads to better outcomes.
Yes, studies show that early cautery, when indicated and feasible, reduces treatment times, likely length of stay, without increasing readmissions. So, if you see it, treat it definitively.
But sometimes you can't see it, the bleeding is too diffuse, TXA failed, cautery isn't an option, or it failed too. Then we're left with packing.
Then we have to pack, and this is where we need to be really thoughtful, especially about what we pack with.
Particularly in our anticoagulated patients, which is a huge chunk of who we admit for this.
Absolutely. The big distinction is resorbable versus non-resorbable packing.
Explain that. What are resorbable options?
Things like Surgicel, oxidized cellulose, gel foam, gelatin sponge, Flusiol, gelatin thrombin matrix. These materials basically dissolve or get broken down by the body over days to weeks.
And why are they preferred in anticoagulated patients?
Because you don't have to remove them. The biggest risk with traditional non-resorbable packing, like ribbon gauze or even some synthetic sponges like Maricel, is that when you pull them out 2 or 3 days later,
You rip off the clot that formed and start the bleeding all over again.
Exactly. With resorbable packing, you avoid that trauma of removal, which is a major advantage in someone whose clotting is already impaired. Less risk of recurrence triggered by the removal itself.
Okay, so resorbable is preferred if the patient's on blood thinners, But sometimes you might need a non-resorbable, like the Maricel sponges or those rapid rhino inflatable balloon tampons.
Yes, if the bleeding is anterior and really refractory, those might be used. They expand to apply pressure.
And if we use one of those non-resorbable packs, what do we need to think about prophylactically?
Antibiotics. Leaving a foreign body packed in the nose for 48-72 hours blocks sinus drainage and can create a breeding ground for bacteria, including Staph aureus.
Leading to sinusitis or, rarely, toxic shock syndrome.
Right. The risk is low, but it's real. So, while the evidence is a bit mixed, many guidelines and institutions recommend prophylactic antibiotics covering staph while non-resorbable packing is in place.
Okay, that covers anterior packing. Now, the really tricky one, posterior epistaxis.
Yeah, the inpatient nemesis. These are usually the ones driving the admission, the ones needing ENT urgently.
How do we manage those initially? It's not usually something a hospitalist packs themselves, is it?
Generally not. Posterior packing requires specialized devices, either inflatable balloons designed to tamponade the posterior choana, like an Epistat or a specific posterior rapid rhino, or, classically, using a Foley catheter inserted through the nose, inflated in the nasopharynx, and pulled forward to create a posterior seal, often combined with anterior packing, too.
Sounds complex and uncomfortable.
It is, and it requires specialist consultation, not just for placement, but because of the risks associated with posterior packing.
What are those specific risks? Why do these patients need close monitoring?
Two main concerns. First, vagal stimulation. The pressure in the nasopharynx can trigger a vagal response, leading to bradycardia, sometimes even hypotension or syncope,
And second,
hypoxia, and hypercarbia. Bilateral nasal obstruction forces mouth breathing. In elderly patients or those with underlying lung disease or sleep apnea, this can lead to reduced oxygen levels and increased CO2 retention.
so any patient with a posterior pack needs to be in a monitored setting, like a step-down unit or ICU, with continuous cardiac and pulse oximetry monitoring.
Absolutely critical. Okay, let's synthesize this for the hospitalist managing these complex cases. A huge piece is navigating anticoagulation and antiplatelets.
It's the tightrope walk, isn't it? Stop the bleeding versus cause a clot.
Exactly. You're balancing the immediate hemorrhage risk against the patient's underlying high risk for DVT, PE, stroke, or maybe stent thrombosis if they're on dual antiplatelet therapy, DAPT.
So it's almost never an automatic stop everything decision. When do we consider reversal or holding these agents?
Usually only in really severe, life-threatening, or hemodynamically compromising bleeds, or those truly refractory to local measures like good packing. And even then, it's a discussion.
A multidisciplinary discussion, ideally, involving cardiology, maybe neurology if it's stroke prevention, or hematology.
Right. Let's talk specifics. Warfarin.
Warfarin's reversible. If the INR is high and the bleed is bad, you'd give vitamin K. If it's critical, you might use 4-factor PCC, Kfenter, for rapid reversal, aiming for an INR maybe below 1.5 temporarily, balancing bleed control with thrombotic risk.
And the DOACs, apixaban or viroxaban.
Generally harder to reverse quickly. Often the strategy is just to hold the drug and let its relatively short half-life work. Unless it's truly life-threatening, then specific reversal agents like andexanet alpha might be considered if available and indicated, but that's usually a critical care or hematology decision.
What about antiplatelets, especially DAPT after a recent coronary stent? That feels particularly high risk to stop.
It is incredibly high risk. Stopping aspirin, or especially the P2Y12 inhibitor, clopidogrel, within months of a stent carries a significant risk of stent thrombosis, which can be fatal.
So what's the approach there?
You prioritize local control measures, pressure, TXA, careful packing, cautery if possible. You only consider holding one or both agents if the bleeding is genuinely life-threatening and refractory to everything else, and always, always in consultation with cardiology.
You need to know why they're on DAPT and when the stent was placed. Primary prevention is different from a stent placed 3 months ago.
Absolutely. Need the JETS to the VASC score, the date of the PCI, the type of stent if possible. Context is everything for that risk-benefit calculation.
Okay. Besides anticoagulation, what about managing specific conditions like HHT?
HHT needs a tailored approach. Starts with aggressive moisturization, saline gels, ointments. Topical or even systemic TXA can be helpful.
And if that's not enough for HHT patients,
then you escalate to more specialized treatments, often guided by ENT or IR. Things like laser ablation or radiofrequency ablation of the specific telangiectasias, sometimes procedures like septodermoplasty.
And I've seen intravenous bevacizumab mentioned, the VEGF inhibitor.
Yes, for severe refractory HH2 cases, IV bevacizumab is increasingly used to try and reduce the number and severity of these abnormal vessels and bleeding episodes. It's a systemic therapy for a systemic vascular disease.
But which leads us to the general question. When does the hospitalist say, okay, this is beyond me, I need specialist help now? What are the triggers for calling ENT or maybe interventional radiology?
Clear triggers should be persistent bleeding despite adequate first-line measures, including well-placed anterior packing, some say bleeding through 2 consecutive packs, any suspicion or confirmation of a posterior bleed, or recurrent severe bleeds requiring multiple visits or transfusions.
And when ENT or IR get involved for those refractory cases, what are the definitive procedures they might offer?
2 main options usually. Surgical arterial ligation or endovascular embolization.
Ligation means?
Usually endoscopic sphenopalatine artery ligation, or SPIL-AL. ENT goes in with an endoscope and clips or cauterizes the main arteries supplying the posterior nose. It's minimally invasive and targets the source.
And embolization?
That's done by interventional radiology. They thread a catheter up through the arteries, usually from the groin, identify the bleeding vessel angiographically, and inject tiny particles or coils to block it off.
Both sound pretty effective.
Yes, both have high success rates, over 90% for acute control. The choice often depends on patient factors, surgeon-radiologist expertise, and the presumed location of the bleed. SPIL-AL might be preferred over prolonged posterior packing due to less patient morbidity. Embolization might be for patients unfit for surgery or with very posterior bleeds.
And often requires a team approach for these really tough ones. ENT, IR, maybe hematology, critical care.
Definitely. Okay, last phase. We've stopped the bleeding, the patient is stable. How do we prevent recurrence after discharge? What's the plan?
Education is key. Tell the patient. No nose picking. Avoid forceful nose blowing. Avoid heavy lifting or straining for at least a week, maybe longer, to let things heal.
And address the local factors, especially dryness.
Absolutely. Recommend regular use of nasal saline sprays or gels. Use a humidifier at home, especially if they use oxygen or CPAP. Keep that nasal mucosa moist.
And manage the underlying stuff. Make sure blood pressure is well controlled. Have a clear plan for restarting or adjusting any anticoagulants or antiplatelets with follow-up arranged.
Clear instructions on when to seek help again if it recurs. And consider outpatient ENT follow-up, especially if the bleed was severe, posterior, or the cause wasn't straightforward.
It really is a systematic approach, isn't it? From ABCs to TXA to targeted cautery packing, managing meds, and finally, prevention.
Yeah, it moves us away from just reacting with potentially uncomfortable or morbid procedures towards a more proactive, evidence-based strategy.
So summing up the key points for our listeners, remember that sequence. Stabilize first, try to localize, apply direct pressure, then critically use topical TXA early.
Right. TXA is the star update here. Better than packing for reducing short-term rebleeding, much better tolerated. Think about it before you think about packing.
And when you do need to pack, especially in anticoagulated patients, strongly consider resorbable materials to avoid that trauma of removal and reduce recurrence risk.
Manage anticoagulation, carefully balance bleeding versus clotting risk. Involve specialists when needed. Know the specifics of why the patient is on those meds.
Okay, so here's a final thought to leave everyone with. We have really strong evidence now for topical TXA. It's effective, it's safe, it's comfortable for patients.
So the question for us, for our hospitals, our EDs, our inpatient units is, how do we change our systems, our protocols, our order sets to really push TXA to the front line?
To make it not just an option for specialists, but a readily available, maybe even expected, early intervention by nurses, by ED docs, by hospitalists.
Could embedding TXA use earlier, more consistently, actually reduce the need for more invasive packing? Cut down on ENT consults for straightforward anterior bleeds, and maybe even shorten length of stay.
It feels like a potential systems-level improvement that could really benefit patients and resource utilization if we can implement it effectively based on this evidence. Something to think about back at your own institutions.